We're pivoting now to our local Duke health system efforts. And the first presentation will be about predicting resource utilization to help prioritize elective operations during COVID-19 pandemic. This will be presented by Ben Goldstein, Associate Professor of Biostatistics and Bioinformatics at Duke, also member of Children's Health Discovery Institute and Duke Clinical Research Institute. Ben?
Right. I'm assuming everyone can see my screen. I want to thank Michael for putting this together and having me speak today. So I'm going to talk about work we've been doing here at Duke to try to use data science to help us better manage the COVID pandemic in the hospital, primarily led by Dr. Chuck Scales in surgery, but there have been folks from surgery, clinical operations, biostatistics, DHTS and informatics, and we've also begun engaging colleagues in Fuqua and the School of Business. So the general context here is that DOHS hospitals ceased most elective procedures during the height of COVID-19 infections. As you can imagine, there was concern that procedures would consume precious resources, things like ICU beds, ventilators. As we got a better handle on the pandemic and we got a better handle on the resources that were being used in the hospital wanted to begin to reopen, but they wanted to do so in a responsible way. So they wanted to be able to identify which resources an upcoming case may require. Ideally, what operations leadership wanted was to be able to look at all upcoming cases and compare this with what the current clinical status and current clinical environment was. So with this in mind, we tackled a data science solution where we leveraged historic data with the goal of creating a predictive model for anticipated resource utilization for the upcoming cases. We turned those predictive results into risk strata to try to inform clinical decision making. We embedded this clinical decision support into a Tableau dashboard that allows the users of this tool, which I'll show in a moment, to visualize the risk associated with upcoming cases. And we wanted to be able to do all this within a workflow so that the dashboard is refreshed every morning. So currently going on in Duke Hospital by 6 a.m. every morning, the dashboard, which I'll show, it is refreshed, and hospital and surgical leadership is looking at this dashboard and making decisions regarding whether a case should proceed or not. These are just some basic predictive modeling results. I'm talking here today because our predictive models actually perform quite well. We looked at predicting 4 different outcomes: length of stay, anticipated length of stay, anticipated need for ICU bed, need for a ventilator, and need to be discharged to a skilled nursing facility. We created a decision rule where the idea was to create categories to guide clinical decision making. And we wanted to make a decision rule that prioritized over versus underestimating of risk. So there's a lot going on here, and I won't spend too much time digging into the slide, but what you have, for example, is that among people who truly would have a 7+ day length of stay, about 60% of them were classified as such. On the flip side, those people who would need to have a short length of stay, a 0 to 2 day length of stay, about 68% of people were correctly classified. We see similar metrics occurring in need for ICU, need for going to a SNF, and need for going to a ventilator. So we were actually very encouraged and excited about the quality of the predictive model, so we moved into our second phase of turning this into a dashboard. So this is the landing page of the dashboard that's been created. This is what we call the executive summary, where it gives the user is looking at it kind of a bird's eye view of what cases are coming on, the various cases that are procedures. There was interest in looking at this across various specialties and service lines. The main view is this calendar view, where each dot represents an upcoming case. So this is the calendar view from actually a couple of weeks ago. Each dot is a particular case. The color coding is that risk strata for that case. So if today, for example, is Wednesday, then those who are looking can look overhead over the next couple of days and see what do the cases look like over the next couple of days? How risky do I see my cases upcoming? You can actually drill into a particular case and get information on that patient. What are other risk metrics for them? What type of case is it? This is a heart procedure, and you can get a more detailed assessment to help again guide that to clinical decision making. The final aspect of the dashboard, which I actually think is the most exciting component, is we embedded in this an ability for to track how well our model has been performing. So this is actually a retrospective look back as the model has gone live. So this is for looking at a predicted ICU length of stay. The green bar indicates that the prediction categories were accurate. A red bar indicates that we were underestimating risk, where a yellow bar was indicating that we were overestimating risk. As we designed the model, we have a bit more overestimation than underestimation, but we think this is really important because as we start thinking about clinical decision support, we want to be able to feed back information to the user as to how good the model is working so that they have a degree of comfort and faith in what data and information we're providing them. I want to really emphasize that individual patient resource needs are really just a piece of the puzzle in decision making. So we're not presenting here a go or no go for a particular case. This is really a way to contextualize a case. Hospital operations leadership is considering things like the clinical urgency of the particular case, the current hospital census, local COVID conditions, and overall case backload. So during a period of time where conditions are stable, they can decide to be more aggressive in bringing in cases. As things begin to ramp up in the hospital, as we're experiencing now, they may decide to be a little bit more conservative. The other aspect that I really want to emphasize here is that this has been a highly successful project. We were able to put this together in about 10 weeks, but that success is really due to an integrative team science approach that really brought together clinicians, operations specialists, and informaticists and statisticians. And with that, I thank you.
Thank you very much, Ben. One question I had, there is a fair amount of discussion in light of the recent FDA guidance about what these predictive tools are intending to do. To what extent do you see the dashboards being used to inform care, one of the added tools in the toolbox, versus them taking over to drive the decision making for the practitioners?
Yeah, no, that's something that we've talked a lot about, even at a higher level, of how to decide between CDS that's really saying do procedure A or give a particular clinical care versus something that's really monitoring workflow. This does fall into the latter category. So to be honest, it's a little bit of a gray area to what extent that it, falls under the FDA guidance. We've been really particular to say this is not a go or no go decision tool. This is a contextualization. There's a lot more information that's needed to really decide whether a case should proceed or not. In some ways, we'd ideally like to get to a full data science approach that incorporates data about local COVID conditions and the rest of the hospital's census. But because we're not there at that point, we're really relying at the end of the day on human decision making to say you're integrating in different pieces of information, and it's your job at the end of the day to decide what you're most comfortable with.
Okay, makes sense. Thank you very much, Ben.